Welcome everybody to this fourth part of the ACNS Peripheral Nerve Diploma webinars. So today we have wonderful speakers. First speaker is Moaaz Elsebaey from UAE. We'll be talking about intraoperative monitoring in nerve surgery. The second speaker is Dr. Chandan Mohanty from India. We'll be talking about general principles of nerve entrapments. The third speaker is Dr. Ferry Sanjaya from Indonesia. We'll be talking about carpal tunnel, and the fourth speaker is Prof. Deborah Garoso. We'll be talking about ulnar nerve entrapments, and the chairs for this event are Dr. Guna Huttomoputra from Indonesia, Prof. Ikapojitapun from Thailand, and Dr. Gopal Seden from Nepal. So we'll begin by a short introductory remarks by our Honorable President, Professor Yogo Kato.
Thanks so much. So I think that today's webinar also the very interesting and very common disease, I think. Let's start, please.
Okay. Thank you. First of all, I'm Ekpochitpon, and my team. I would like to share this session, the fourth session of the. Hello, everyone.
Please go ahead. Sorry.
Okay. So welcome to the fourth the ACNS Peripheral Nerve Surgery webinar. I'm Ekpochitpon, and with my team, Guna Putra and Gopal Sedan, we will share through all four sessions today. Okay, so let's start with the first session. Dr. Moaaz Elsebaey. I'd like to introduce a little bit about Dr. Moaaz. Actually, he's not a neurosurgeon, not an orthopedic surgeon, but he's an engineer. He's the engineer who interested in neurophysiology. He's from UAE. So his talk today will be the intraoperative monitoring in nerve surgery. So please welcome Dr. Moaaz.
Thanks so much for the opportunity. It's a great pleasure to be among great speakers, and I'm very happy to present a talk about the intraoperative neuromonitoring, especially in the peripheral neurosurgery, because it's a very well recognized and established service in brain and spine surgeries, and even some of the ENT surgeries. But we can see some lack of usage in the peripheral nerve surgeries. So this is something we would like to highlight. I will start about the basics, so all the audience will be get a benefit of what is the intraoperative neuromonitoring, what is the concepts and modalities, and how to utilize in different surgeries. And inshallah, maybe in next webinars we can talk in details about specific surgeries in more details. So if you allow me, can share my screen now?
Yes, please.
Great. Well,
okay,
so
I can see it, right?
Yeah, perfect. Yeah, so again, the intraoperative neurophysiological monitoring is usually you can refer to as IOM or IONM. It's a part of the neurology, and it's a kind of neurological studies that we do intraoperatively to monitor the activity of the fibers we are concerned of, and also to make sure about the functionality to secure a best outcome. So about the concept of neuromonitoring. So as it's a monitoring, it's not actually doing a monitoring only. So in intraoperative, we do two things. One of mapping concept, and the other part is the monitoring concept. We started with the mapping, and the mapping is identifying and localizing the concerned fibers and being able to trace it, like the nerves itself. So I would like to find the nerve and to be able to trace it anatomically, whether in clear or unclear construction. And the performer in this mapping technique is the surgeon. So you depend on the surgeon himself, because usually he uses a handheld tool to be able to stimulate and sometimes to record. We talk in details how to stimulate and record, because it's very well known that usually we stimulate only. About the tools that we use, usually it's a probe, and the probe can be monopolar, bipolar, or tripolar. The modalities that we do for this kind of mapping, whether it's a triggered EMG or SNAP. SNAP is a compound nerve action potential that you record and stimulate from the nerve itself. The other concept, which is the monitoring, which is well known. It's observing the activity of the concerned fibers and checking its activity. For examples, we do the spontaneous EMG, the MEP, which is motor evoked potentials, SSAP, somatosensory evoked potentials, and train of 4. This is done passively by a neurophysiologist is in the room, and the surgeon is not interfering at all by this. So just to get the feedback from the neurophysiologist, and usually the neurophysiologist is using some needles that preoperatively placed for this objective. So those are the main concepts. Now we come to the modalities. Modalities is the kind of test that we perform. So we have the EMG consists of 2. Spontaneous, as we mentioned, this is a free-running electromyograph, gives a live feedback from the recording channels. So I know that I have a certain nerve. I'm concerned about this in this surgery. So I select the muscles and place my recording needles in these channels to be able to monitor this nerve activity. And we have the triggered EMG, which is the same concept, same recording, but I stimulate the nerve and get a response. And then I evaluate this response. How good is this response? So this is the triggered EMG. About the MEP, it's a transcranial motor evoked potentials that I stimulate from the cortex, from the brain, and I record again, like the AMG, I record from the distal peripheral muscles. So it's covering the whole descending pathways, and it's very important because it's covering the whole pathway, and it's very reliable. The SSAP is also very, very important because all the previous are only can give you feedback about the motor part of the nerve, but not the sensory. So the somatosensory gives you information about the functionality of the nerve for the somatosensory. One of the most important that we don't see as very commonly used and sometimes not correctly used is the train of 4. The train of 4 is monitoring the neuromuscular junction, and it's a very important for the EMG and MEP because the neuromuscular junction is in between the nerve and the muscle. So if you have any blockage due to muscle relaxant, you will not be able to have a reliable EMG or MEP. So it's very, very important. Some details about the EMG now. So we said it's live nerve activity, that we can have some kind of abnormalities, fibrillation or fasciculation or neuromyotonic discharge or myotonic discharge. This kind of abnormality that gives a feedback to the surgeon. In the peripheral nerve surgery, actually, because we're working directly on the nerve, so we can see a lot of activities, but experienced neurophysiologists will be able to differentiate between what is normal, what is abnormal, and get a reliable feedback to the surgeon. The limitation in this case that the EMG cannot confirm or assure the functionality. So if you have a stable EMG, it does not mean the nerve is functioning, okay? And it's need, as I mentioned, is experienced specialists to differentiate between the normal and abnormal activity. And it's not reliable with a muscle relaxant, okay? The triggered EMG, as we mentioned, we stimulate to be able to get a response. And the triggered EMG, to be able to have a reliable one, you should have a baseline from the proximal part of the nerve before the surgery to make sure that you have a baseline. This baseline, intraoperatively, you will be able to repeat the stimulation and compare the response to make sure that there is no difference between or no change to the functionality. And this also can be done by the MEP. If you stimulate passively without the surgeon is stimulating, still you can have some feedback, but the triggered EMG will help you also to trace the nerve in some of the unclear surgeries or revision surgeries. The limitation here, this is very important for the surgeon to understand it, that when you use a monopolar and bipolar, there is a slide for this one, but there is something called current shunt. If there is a fluid on the nerve, this can cause the electrical current to move to another nerve or other tissue, and you will not have a reliable response. Current jump using a monopolar, the monopolar is a spreading current, so also you can stimulate more than the concerned nerve. Again, it's not reliable with a muscle relaxant, and it cannot confirm the sensory functionality. This is a chart. You can keep it for your reference. What you're going to monitor and what muscle you need to select to have in your modalities. This works for EMG and MAP. Now about the monopolar, bipolar, and tripolar. So the monopolar is high sensitive because it's spreading the current all around the area. So if you have unclear structure and you cannot find the nerve, you can use a monopolar probe. It spreads the current, and as much as you increase the currents, it's giving you a bigger space. So there's something called thumb concept or rule of thumb. This is 1 milliamperes equals to 1 millimeter distance. So if you are 3 milliamperes getting you some response, means you are 3 millimeter far from the nerve, yeah, and so on. But it's less specific, as we mentioned, because it's a spread the current, so you can stimulate widely. And it needs a reference needle. So the probe is spread the current from the probe tip to a reference needle that usually we keep it far from the stimulation site. The usage, as we mentioned, nerve finding in unclear structures, and it comes in different shapes. The bipolar is different. The bipolar is very sensitive, and it's less sensitive, sorry, and very high specific. It does not need any reference, and it's ideal for nerve identification and tracing. Also, it comes in a very different shapes that you can see examples below in the pictures. And similar to it is the tripolar. The tripolar is just has 2 anodes and 1 cathode, so it's even more specific and has a very less stimulation artifacts that is ideal for the SNAP, the compound nerve action potential. So you can stimulate by the tripolar and record by the bipolar probe over the nerve. Those what you can in this picture, you'll be able to see how you stimulate. So in the first on the one on picture on the left, the monopolar, as we mentioned, it spreads the current all around, while the bipolar, it's between the 2 poles, so it's very small area of current spread. The stimulation site is very important because it's make a difference. So if the tumor, let's say in this picture, is at the elbow level and you are stimulating at the wrist and recording from the hand, still you get a good response. This doesn't mean that the nerve is functioning because you're stimulating distally, right? So the most important is to stimulate proximal, to keep the tumor or the injury or the concerned side of the nerve in between of the stimulation and recording. The wave morphology on the third, this is the response that you get intraoperatively, and it has a latency and it has amplitude. The latency gives you how far is the distance from the stimulation to the recording point, and the amplitude is the strength of this response. Latency is not very important here. You don't need to give too much care to it at the moment, but the amplitude is really very important. Well, now we are done with the EMG. As we mentioned, this it's all motor. It's not giving you any information about the sensory. So the sensory, as a monitoring, intraoperative monitoring technique, so it's only somatosensory monitoring. So it does not give you information about the spinothalamic. It does not give you a pain or temperature feedback. Okay, so it's covered the whole ascending pathway from the nerve up to the cortex. And you can record from any points throughout the pathway. So you can record to stimulate distal, let's say from the peripheral nerve, the median, the ulnar, the radial, okay? And you can record it from the elbow, you can record it from the ear point, you can record it from the spine, or even the cortex. So this kind of limitation, don't keep it in your mind that the setup is usually we record it from the cortex, because there is a lot of structure, and the SSAB is sensitive also to the vascular cases. So let's say you're working in the peripheral nerve and you're recording only from the cortex. If you get any compression on the neck due to the carotid, you may get a drop on the SSAB from the cortical recording point. And this will not be related to the surgery at all. So again, SSAB should be performed by a neurophysiologist that will be able to give you a reliable feedback. The limitation for it, it takes time for averaging, and it does not cover the pain and temperature. This is sample of the data that we do in the surgeries. So as you can see, each point here, the air point, and then we have the C-spine level, and we have the subcortical and cortical. Everyone comes with a different latency and amplitude, and this will help us very much to understand and to monitor. So this is why it's important, because actually sometimes the patient could get a kind of injury, like a brachial plexus injury, due to the positioning, not due to the surgery itself. So it's a very important, more than only the surgery. So neuromonitoring is not only specifically to the concerned fibers that we are working on. The MEP, as we mentioned earlier, it's covering the whole tract, so you will be able to passively stimulate and make sure that the whole motor unit is active and functioning throughout the surgery, and with no interference from the surgeon. It's just affected by the inhalation, so it's preferred to go TIVA completely, or maximum 0.5 Mach. To have no muscle relaxant, and we should be careful using a bite protection to avoid tongue injury. And sometimes because of the stimulation, the body moves, and this is sometimes irritating to the surgeon. We need to be careful if the patient has a stimulation implant, like a DBS, pacemaker, vagus nerve stimulator, or hypoglossal nerve stimulator. This is an example of the data. We have left and right. Usually we have a proximal to the site of the recording and distal to the site of the surgery as well, to make sure that we have some reference. And then we compare left and right, every response, to make sure also that we have a reliable feedback. The train of 4 that we mentioned, train of 4 is to validate the EMG, the MEP, the tricard EMG, and even if you are not recording and you have a muscle relaxant, you will not be able to see a twitch. So train of 4 is very important, even if you're just stimulating, okay? So you can use it from the median or ulnar nerve. If you're stimulating the median, you can record it from the thinner. If you're stimulating the ulnar nerve, you can record it from the hypothinner. Also, if you're doing lower limb, you can stimulate the posterior tibial nerve and record from AAH muscle. Something limitation for it is the neuropathy. If the patient is very diabetic, this can affect the train of 4. So the patient could be having no relaxant, but unfortunately, it's affecting the nerve. So you don't have a train of 4. This is the only limitation for the train of 4, but it's very essential, as we mentioned. One of the things, the visual train of 4 is not reliable, because the visual does not give you a quantitative feedback. This is some of the studies that we made. So if you have 3 twitches out of the 4, this means that 65 to 75% is blocked already. Yeah, and if you have still 4 out of 4 twitches, but less than 70%, you still have a big chance of blockage. So at least quantitative, you should have 70%, which is train 4 divided by train 1. The new machines currently, they are doing it automatically. They can give you a number like in this picture. What we recommend in conclusion, we recommend a multimodal IOM that covers the motor, the sensory, and also cover the positioning and some vascular information to avoid any ischemic events. And please do not ignore the train of 4 in all your surgeries whenever you're going to do IOM. In summary, IOM multimodal helps surgeons to proceed safely and secure best outcome. It's very important for the surgeon to understand the different concepts and different modalities. And of course, whenever possible, having experienced IOM specialists avoid a false interpretation and keep the surgery smooth. Again, thank you so much, and we can receive all your questions by email or by the end of the session. Thank you.
So we don't have question from the online yet, but I like to give you a comment. I mean, the neurophysiology monitoring is very, we relied on neurophysiology monitoring every time we do nerve surgery. It's very important in our field. I think I cannot do nerve surgery without nerve monitoring. So I think it's my privilege to learn from you, from the engineer who are dedicated neurophysiologists. the thing is the information you give is variable, and it's like an in-depth background of what we're doing today. As a neurosurgeon, I think I don't like physics. I don't know much about electricity, so I don't get it. Sometimes I don't know what to use: monopolar, bipolar, tripolar. I don't know what to use. But yeah, you give a clear kind of guideline what we can do in the clinical practice. Thank you very much.
You're very welcome. Thank you.
Any question? You can type the question into Q&A right now. So I just read it for you from Thompson. Okay, there is a question from Dr. Turnwell. In a patient with high-grade brachial plexus injury, how do you intraoperatively decide between the external neurolysis, nerve grafting, or abandon, repair, and proceeding to the nerve transfer? And which intraoperative neurophysiological modality is the most reliable for this decision?
Yeah, sure. It's a very important questions, and I think this is what we are studying in Victor Deborah's cases. We do many of reconstruction brachial plexus surgeries, and it's always questionable when to do grafting. Will the nerve do I need to do grafting or no? So we do a multimodal still for this kind of surgeries, and we do the ulnar, we do the median and radial all together, and of course we take a contralateral reference from the other limb, and we do the motor evoked potentials covering all the muscles, the flexor, the extensors, and yeah, from the trapezius till the fingers as well. And then we depend also very much on the triggered EMG. So by the triggered EMG, we evaluate the nerve, we stimulate, and what we are trying to do is specifically, because intraoperatively, sometimes the response is affected by anesthesia, right? So we depend on patient, yeah. And we have some reliable response. If the amplitude of the nerve is more than 1 millivolt, I think this should be okay. You don't need to do a grafting over 1 milli. If you have the amplitude that we talked about, the latency and amplitude. The latency is not very important in this case, but the amplitude is very important. So if you have amplitude over 1 millivolt, this should be a good nerve, and it should recover by the decompression, but with no grafting. But if less than that, it's recommended, because yeah, it's usually this means a big sign of that the nerve is not really functioning very well. We of course the preoperative clinical study and the neurological study is very important to help us to take the decision as well. So as I mentioned, the neurophysiology is part of the neurology, so we work as a team. So the examination of the patient is very important, the age of the patient is very important, and for how long, like if you had kind of injury, for how long, is it chronic or acute injury? Okay, and this also will help us, because the acute, usually if you take a right decision, it will be reversible. The chronic, it takes a very long time, or the congenital ones.
Okay, thank you. I think we have 3 or 4 more questions. Dr. Moaaz, can you answer the question in the Q&A session? Because I think we have 3 more, and I think we cannot answer the questions here in our live session. So I think yes, you can type in the question, and I think every single answer we'll try to answer that. This is okay.
Sure,
okay,
sure, with pleasure. I'll take care of it.
So please type in your question, everyone. So let's move to the next session. Dr. Chandan. So the next session by Dr. Chandan Mohanty. He is my friend from Mumbai, India. He is a neurosurgeon, one of the ACNS and the ACNS committee. Right now, he is an associate professor of neurosurgery at Bombay Hospital Institute of Medical Science. So today, Dr. Chandan will introduce us with the concept of general principle on nerve entrapment. Please welcome Dr. Chandan.
Thank you, Jake, for the kind introduction. Hello to all the fellow panelists. Without too much wasting too much time, we will be covering about the general principles of nerve entrapment and followed by two very exciting lectures on the most common types of nerve entrapment. So I'll try to give you a brief overview of the entire epidemiology and management principles of nerve entrapment. So I do not have any disclosure. So we'll be looking at epidemiology, pathophysiology, the role of electrophysiology covered very well by our previous speaker, radiology, some differential diagnosis which can make a difference in the management of the patient, and the surgical principles. So entrapment neuropathy has been defined as a compression neuropathy which occurs at very specific places where the nerves are confined to narrow anatomical pathways, and therefore they are very susceptible to constricting pressure. So when we look at epidemiology, the upper limb involvement as far as nerve entrapment is much more common than lower limb involvement. The most common being the carpal tunnel syndrome, which is the median nerve compression at the wrist. And its incidence varies in literature, but the higher end is as high as 193 patients out of 100,000. You usually have a more female preponderance and more commonly seen in the age groups of 40 to 60 years. In pregnancy, you sometimes also see a carpal tunnel syndrome, which is, again, the incidence is quite varied, but you can see it as low as 3% of patients to as high as 60% of pregnant patients. Ulnar nerve compression at the elbow is the second most common type of nerve entrapment. We are having lectures on that. The incidence is quite low compared to carpal tunnel, which is about 21 to 25 per 100,000 patients. Ulnar nerve neuropathy has a more male preponderance compared to carpal tunnel. So when we look at modes of entrapment, there are mainly three modes. Whenever we talk about nerve entrapment, this is the external factors, which is the one which we'll be dealing in this talk and the subsequent lectures, which is basically an increase in pressure in the osteomuscular tunnel, and which can affect the gliding of the nerve. And even when the compression is completely removed, you might still have some altered properties of gliding. So this is the external factors which are the most common and which we will be focusing in this lecture. There are also other factors which can contribute to entrapment, like internally from the nerve itself, such as alcoholism, diabetes, uremia, carcinoma, etc. You can also have extraneural compressions, mainly secondary to a mass or a mass occupying lesion or nerve tumors in the osteomuscular tunnel. You can also have extra stress or strain on the nerve when you have a malunited fracture or variations of anomalous muscles. So when you look at compression, the first step is the breakdown of the blood and the nerve barrier. This is then followed by edema. Then edema leads to thickening of the perineurium, which increases the endoneural pressure, causing ischemic changes in the microneural circulation, which then leads to local demyelination. Then it's not local and focal demyelination, and then eventually leads to axonal degeneration. I think this is a very important flow chart to understand the steps of nerve compression and how it actually progresses in patients. So typically speaking, the last stage of any kind of nerve compression is the axonal loss. Typically, the large and the myelinated axons are affected first. The unmyelinated fibers are somewhat more resistant and are affected last. So we are all aware of the very typical clinical features which are associated with nerve compression, like the drop hand, claw hand, ape hand, etc. So typically the patients present with a deep ache or painful paresthesia, pins and needle sensation. Symptoms are typically worse in the night when there is some edema in the osteomuscular tunnel, which kind of physiologically constricts the nerve and decreases the circulation, which leads to pain. And when the patient performs repetitive movements like flicking or shaking of hands, this nerve eventually glides through the tunnel, and then the circulation around the nerve is improved, and then it restores the function. This nocturnal worsening of symptoms is very, very characteristic of entrapment neuropathies. You can also have weakness along the distribution of the nerve. Tinel sign, which is basically percussion along the nerve, can also reproduce the symptoms. Then we also have provocative tests like the Phalen's test and the reverse Phalin test, which are relevant for carpal tunnel, and direct compression on the site. For example, in carpal tunnel, if you perform a direct compression on the flexor retinaculum, you can also see reproduction of symptoms. So you always remember that entrapment neuropathy is a clinical diagnosis. There are certain features which will clinch the diagnosis. For example, this OK sign, which is usually seen in the anterior interosseous nerve entrapment, where there is selective weakness of the flexor pollicis longus and the flexor digitorum profundus. So now this patient had come to our clinic about 2 to 3 weeks back, complaining of carpal tunnel syndrome. Symptoms were very, very typical. But the moment you see the patient, you saw that her faces had become coarse, her jaw was quite big, her ear, if you can see the size of the ear, were quite big. Relatives, on asking again, did notice that her facial features had coarsened, her hands and feet were a bit bigger. Her old shoes, she was not able to use them, so she had actually had to increase the size of the shoe. So all this were indicator of acromegaly, and then this patient underwent an MRI, and you can see that had pituitary microadenoma. So it's again very important that even though patients come to you for nerve entrapment, you can have systemic disorders which can cause nerve entrapment, and you should be mindful enough to identify them. So now there are certain mimics of entrapment neuropathy. For example, this radicular pain is usually very common, but the C5 radiculopathy can be secondary to a suprascapular nerve entrapment, whereas the sensory symptoms of C6 radiculopathy may mimic a carpal tunnel syndrome, and so forth. When we look at causes of entrapment, it's also important to understand that there are also medical causes of entrapment. Things like amyloidosis, diabetes, hypothyroidism, even infectious diseases like leprosy, Lyme's disease are also to be kept in differential diagnosis if the patient has corresponding symptoms. Obviously, from the surgical perspective, it's also important to consider tumors or nerve tumors, which may sometimes mimic the symptoms of nerve entrapment. So after a wonderful lecture on electrophysiology, I won't spend too much time on the electrophysiological aspect, but electrophysiology also has a very important role in entrapment neuropathy. The preoperative electrophysiological evaluation. So a drop of latency of more than 4 milliseconds is usually considered diagnostic of carpal tunnel syndrome. For cubital tunnel syndrome, in the elbow around the ulnar nerve, if you see a drop of the compound motor action potential of more than 20%, or a nerve conduction velocity drop of more than 10 meters per second, then it's usually suggestive of a cubital tunnel syndrome. EMGs are also useful because then they can differentiate a neuropathy from a radiculopathy or even from a proximal brachial plexus lesion. So now, when we look at or interpret electrophysiology, it's also important that you are aware of certain type of anatomical variations. For example, this is a very common and well-known variation called as a Martin-Gruber anastomosis, which is between the ulnar and the median nerve. It has many types and subtypes, and the incidence is pretty high. It's seen in about 1/3 of the patients. So this can lead to misdiagnosis in certain cases. So if you check the compound motor action potential over the adductopolysis brevis, you might misdiagnose it as carpal tunnel, even though it might be because of the anastomosis. Now, when you come to radiology, radiology is again very important. We look at ultrasound first. So ultrasound is a very nice tool. It is fast, it is economical. You can see the nerve completely along its entire course. You can look at the compression of the nerve. It has a very high resolution. On the cross section, normally you see a very typical honeycomb appearance of the nerve. And if it is damaged or altered, it's usually suggestive of an entrapment neuropathy. The cross-sectional area of the nerve, if it's more than 10 to 12 square millimeters, it is usually very, very sensitive for diagnosis of carpal tunnel syndrome. Similarly, if the cross-sectional area of the ulnar nerve at the elbow is about 9 to 13 square millimeters, any value more than that is again very suggestive of cubital tunnel syndrome. The main issue being it is very operator dependent, and the view can sometimes be limited by the depth as well as the bone. So if we want a more higher resolution imaging, then we usually prefer an MRI. MRI obviously can detect masses, inflammation. It can also look for any change in the internal architecture of the nerve. The denervated muscle looks hyper intense on the T2 neurography, and it starts at about 4 days. You can see maximum till about 4 months, and it lasts up to 2 years. So it is pretty sensitive, irrespective of the duration of the symptoms. Similar to ultrasonography, you can also see flattening of the nerve. You can see a proximal enlargement and swelling of the nerve with T2 hyperintensity changes. Problem again is the cost, the availability, and the time required to perform these tests. So for example, this patient, you can see that both the supraspinatus and the infraspinatus nerves are showing denervation. Whereas in the next case, you see the supraspinatus muscle is kind of free, but there is some changes which are seen in the infraspinatus nerve. So you can actually localize that the lesion is is after the bifurcation of the suprascapular nerve, where the nerve supply to the supraspinatus is intact, but the nerve supply to the infraspinatus is affected. So MRI also sometimes has a very important localizing value of entrapment. Now, for this example, when you are dealing with extraneural compressions or compressions because of masses, so you can see this is ulnar nerve compression. You can see a very tortuous vessel here, which is compressing the ulnar nerve in the Guyon's canal. Again, MRI is very important and very useful to identify these extraneural sources of compression. So MRI can also sometimes identify anatomical variation. So, for example, ligament of Struthers is a well-known factor causing acant deformity or affection of the median nerve. You can see this structure on the MRI and identify the site of compression. Now, when you look at treatment, the treatment is pretty straightforward. When the patient does not have sensory loss or motor weakness, and mainly nocturnal symptoms, splinting can be performed. You can suggest patients activity modification and anti-inflammatory medications. Even a short dose of steroids has been recommended for patients without any sensory loss or motor loss. Surgery is the treatment of choice for entrapment neuropathy, especially whenever there is sensory loss, motor weakness, or any kind of severe refractory pain. The outcomes of surgery, even long term, are much, much better compared to medical management. Surgery can usually be done under local anesthesia and sedation. We generally tend to use microscopes or loop. Some amount of magnification usually helps in performing the surgery. Now, coming to the general principles of surgery, it's important that you have an adequate surgical exposure, and you need to identify the normal nerve, both proximal and distal to the lesion. Now, the dissection generally, as a rule of thumb, is started from the healthy tissue and then reaches the pathological site. If you have Sometimes you can have insufficient decompression, which may actually be secondary to the fact that you did not visualize the nerve or did not expose the nerve well. So before separating the nerve from the compressing structure, we usually perform a baseline electrophysiological intraoperative examination. And then once the nerve is decompressed, we perform this again to see if there is if there is any positive change in the electrophysiological parameters. You also can sometimes palpate a compressed nerve. If you feel that the texture of the nerve is woody, or the nerve is thickened, or nerve is hard, there sometimes some authors have also suggested opening or partial excision of the epineurium, which is the outer layer of the nerve, till it becomes soft and helps to improve the circulation in the nerve. Now, very aggressive internal neurolysis is very rarely required in entrapment neuropathies. The main idea is to avoid perineurium dissection whenever it is unscarred, because any attempt to do that will end up decreasing the nerve supply, affecting the nerve supply, and then worsening the pain and the deficit in the patient. It is important that you perform a nice tension-free decompression so that the nerve normally glides along the symptoms. It's important to perform a complete 360-degree decompression, and always check for compression. Always check for dynamic compression once your surgery is done, to look for either subluxation or residual compressions. For example, in this patient with the cubital tunnel syndrome, once the decompression is done, you always put the elbow through the entire range of motion to make sure that the nerve is completely free along the course, and also the fact that the nerve does not subluxate. Post-operatively, it is important to avoid scarring and adhesions between the nerve and surrounding tissues. Hence, we do not ask the patients to have a prolonged immobilization. Early mobilization of the nerve of the patient and the joint movement is usually preferred. If tendons or muscles have been sectioned or repaired, like in transposition of the nerve, then mobilization may be performed after 1 week. But usually, our patients, we start mobilization of the patient within the first 24 to 48 hours. So my take-home message is that after the breakage of the blood-nerve barrier, demyelination occurs first, and the axonal loss happens last. You need to have a thorough knowledge of both the anatomy and the anatomical variations. Entrapment is a clinical, most of the time clinical, and sometimes also electrophysiological diagnosis. You need to be aware of the differential diagnosis and mimics both surgical, spinal, and medical causes of entrapment. Imaging is, I find it useful whenever you have odd clinical features, or you have suspicion of secondary causes or tumors or masses. Imaging is also used for localization, in finding out anatomical variations, and also in redo surgeries in cases which come with entrapment or tethering of the nerve again. If there is no neurodeficits or the pain is mild to moderate, then a trial of medical management and splinting is reasonable. Surgery is generally the treatment of choice whenever you have neurodeficits. And good exposure, doing a complete 360 decompression, ruling out dynamic compression and a tensionless decompression is critical. The need to do any kind of extensive neurolysis is extremely rare, and please mobilize your patients early to avoid any long-term scarring. Thank you.
Thank you, Dr. Chandan. Very great talk. So I think we have 3 questions for you. Could you kindly answer the question in the Q&A session?
Sure.
I recap those answers and maybe post in our social media later for the one who did not see to see the question and answer. So let's move to the next one. Thank you, Chandan.
Thank you.
So, Kanna, could you please introduce next session?
Okay, Jake. The next section, the next speaker will be Professor Ferry Sanjaya. He's from Indonesia. He is one of the peripheral nerve peripheral nerve surgery performer in Indonesia. So he works at Siloam Hospital and lecture in the Pelita Harapan University. So the next subject will be carpal tunnel syndrome. Okay, please, Professor Ferry Sanjaya.
Thank you, Dr. Guna and Jake. Thank you for having me. So I'm going to cover carpal tunnel syndrome. Dr. Chandan actually has covered a lot of a majority part of my topics here. So I'm just going to go through my presentation. Wait, sure. Okay. So I'm going to talk about carpal tunnel syndrome. Carpal tunnel syndrome is the most common entrapment neuropathy, and carpal tunnel syndrome is caused by compressions of the distal median nerve within the carpal tunnel. It is more common in women compared to men, and the incidence is about 1% in general populations and higher in industries that require repetitive use of hand or wrist movements. Carpal tunnel syndrome mostly occurred in middle-aged patient group, 40 to 60 years old. The risk factors, Dr. Chandan has covered this extensively, so I'm just going to go through this briefly. So again, local factor due to increased volume of the content and a reduction in capacity of the tunnel. And there are systemic factors that's also been described by Dr. Chandan, and one of the also important factors is the repetitive or excessive wrist movement. But in most patients, it's difficult to find a specific condition that caused the carpal tunnel syndrome. So mostly it's idiopathic. So we consider that the repetitive hand motion is the one that is probably causing the symptoms or the carpal tunnel syndrome. The symptoms of carpal tunnel syndrome is typically patient will complain having aching, burning, tingling sensation, and also numbness in the median innervated area. If you look up in the internet, typically this is the picture that you find. So the symptoms involve the first to third digit and half, the radial half of the fourth digit. But this is actually not accurate because the thinner base is innervated by the sensory nerve. The sensory nerve branch of the median nerve is coming, actually the branching point is proximal to the carpal tunnel. So typically in carpal tunnel syndrome, the thinner base is normal sensation. The patient can also complain of having a proximal forearm or even shoulder pain. And typically, patient also complain having nocturnal pain. Patient often awakens the patient due to the pain or numbness or paresthesia during the night, and patient usually shake off their hands to obtain relief. In late stage, patient also can have or complain grip weakness and tend to drop things. So again, here on examination, you can see on the picture here that on early stage, typically patient, we usually find normal findings in patient on early stage. While on moderate or severe cases, you can see we can find objective finding of hypoesthesia in the median distributions minus the thinner base. And on motor examination, we can find weakness in the lobe muscle, especially on the abductor pollicis brevis. So I think this is the most important muscle that we need to test. And we also need to confirm that there is no weakness on the more proximal median innervated muscles. For example, Dr. Chandan has already showed the picture of patients showing OK sign, which is the muscle that is innervated by anterior interosseous nerve, which is a branch of the median nerve that is coming proximal to the carpal tunnel. So if you see patients with suspected median carpal tunnel syndrome, but the patient also showed deficits in the AIN innervated muscle, that means that the pathology is possibly proximal to the carpal tunnel. In late stage, we can also see patients with tenoral atrophy. Like in this picture here, you can see the severe atrophy of the abductor pollicis brevis. And also in this picture here, sometimes you can see patient with median clawing. PES has also been described by Dr. Chandan, tinel sign, the repercussions of the median nerve over the transverse carpal ligament, and Fallon test, and also Durkheim's test, which is the compressions of the direct compression of the flexor retinaculum. Diagnostic test, most important one, I think it's the nerve conduction velocity study. We can see prolonged distal sensory latency, decrease or absent snaps, and also prolonged distal onset latency of the motor component. Electromyography is rarely used, but sometimes you need this if you want to differentiate the condition to other pathologies such as cervical radiculopathy or a more proximal median nerve compression or pathology. Ultrasound and MRI has also been described by Dr. Chandan, so I'm not going to go too long there. So for the management, for early conditions with minimal symptoms, you can treat the patient conservatively with risplints, anti-inflammatory drugs, and we can also do injection with steroid around the median nerve. This is maybe beneficial, but there's also risk of injection injury. The other option is to do a hydrodissection or with dextrose prolotherapy or PRP or glucopuncture, usually done under ultrasound guidance. For surgical management, we usually do it for patients with in the more moderate to advanced stages or patient who has been treated conservatively but fail. There are options for our surgical method. We can do open surgery or mini open surgery. This is the technique that I usually do. We can also do endoscopic decompression or also other technique. I think the most important thing is a complete release of the carpal tunnel. So it doesn't matter what technique you use, as long as you can release the nerve completely in a safe manner. I think that's the most important thing. For the anatomy, so we know that the carpal tunnel is bounded medially and laterally, and also the floor is by the wrist bone. So on the medial side, on the radial side, it's bounded by the trapezium and the scaphoid, and on the medial side or the ulnar side is bounded by the hamate and the pisiform. So the transverse carpal ligament is attached to these 4 bones here. And then this is the cross-sectional anatomy of the carpal tunnel. Again, we see that the medial and lateral and the floor of the carpal tunnel is bounded by this bony structure. And above it, it's covered by the transverse carpal ligament. Inside the carpal tunnel, the median nerve is traveling on the right under the transverse carpal ligament with 9 flexor tendons. The 4 FDS tendons, 4 FDP, and 1 flexor digitorum profundus. This is the typical incision for the carpal tunnel, the outline. I usually use the 3rd web space here. And here in the anatomy, you can see that there's a palmar branch of the median nerve that I mentioned before. You can see that the branching point is proximal to the carpal tunnel. So in patient with carpal tunnel syndrome, typically the thinner base is usually normal sensation. And this branch is also important to note during the surgery to make sure that we don't injure it, which may cause traumatic neuroma and causes pain. This is the Kaplan's cardinal line. So for Kaplan's cardinal line, we make this a line from the first web space to the distal part of the pisiform. So the incision usually started from the distal wrist crease to the just right at the Kaplan's cardinal line here. Distal to this line, you can see that there's a superficial palmar arch going across. So this is also the structure that we need to pay attention to during the complete release of the transverse carpal ligament to make sure that we don't injure the nerve. The recurrent thinner branch typically arises from the radial part of the median nerve, distal to the transverse carpal ligament. But there has been descriptions about the anatomical variations of this nerve. This nerve can be found sometimes arising on the ulnar side of the nerve. Sometimes it can arise subligamatously, or sometimes it can also pierce the transverse carpal ligament before innervating the thinner muscles. So I think the most important thing is to do the surgery under direct visualizations, making sure that when we section the transverse carpal ligament, we don't injure this nerve. So the incision that has been described before, for the placement for the incisions, typically place the incision slightly ulnar to the median nerve. So that's the Kaplan's cardinal line. And this is the line that we make from the third web space, or we can go a little bit ulnar here on the mid portions of the fourth finger. And then the incision stretching from the distal wrist crease and to the Kaplan's cardinal line. This is some picture from the surgery. So after we open the skin and the subcutaneous tissue, we'll see the palmar aponeurosis of the palmaris longus. You can just cut this sharply, and then we'll find the transverse carpal ligament. And then, excuse me, sorry. So after carefully sectioning the mid portions of the transverse carpal ligament, we can put in the mosquito. I usually use mosquito to protect the nerve, and then cut the transverse carpal ligament completely under direct visualizations, distally and proximally. So I usually use a sense retractor like this to lift the skin and then see the transverse carpal ligament and cut it under direct vision. So like this. So distally, we can see the fat pad that signifies that the transverse carpal ligament has been completely released. And proximally, I usually flex the wrist a little bit to visualize the transverse carpal ligament more easily. And then after the complete release of the transverse carpal ligament, I usually use a small mosquito to see how far I've gone in releasing the transverse carpal ligament. Post-op care, I think this is also very important. Dr. Chandan has also mentioned that in patients with decompressive carpal tunnel release or other entrapment neuropathy, we usually don't immobilize the patients for a long period of time. We encourage the patients to move the fingers through full range of motions, and also to move the wrist gently to make sure that the tendon and nerve gliding inside the carpal tunnel is maintained. This is, I think, also very important part of in the management of patients with carpal tunnel release. I've seen some patients who has been gone through this surgery, but then they have problems after the surgery because of the adhesion. So the patient having a lot of pains on the base of the palm, and limited range of motions of the fingers due to this adhesion. So for pearls and pitfalls, the carpal tunnel syndrome is characterized by nocturnal pain with paresthesia and numbness, and usually relieved with hand shaking. And surgical release of the transverse carpal ligament is associated with excellent result in the majority of patients. Of course, we would advise to do the surgery in patients with significant symptoms in moderate cases, so we don't wait for too long for optimal result. And incomplete sectionings of the transverse carpal ligament result in treatment failure. I think this is also very important to make sure. I've seen a patient who has surgery in other hospital, and the patient is still having problem or still having symptoms after surgery. And when we do the another surgery to explore the median nerve, we found that the median nerve has not completely released. There's still parts of the transverse carpal ligament that has not been completely sectioned. And proper post-op mobilization is also very important, as I have mentioned before. Thank you.
Thank you, Professor Ferry, for the nice presentation. So this is a carpal tunnel syndrome. That's the most cases that we will find in our daily practice, and we'll do and many surgeons will do it as well, huh? Okay, maybe there is a question for Professor Ferry. There are two questions, I think. Maybe you can
You can
answer it.
type it.
Type it. Yeah.
We can move ahead.
Yes, I will type the answer. Thank you.
Okay, thank you. So we move on to our last session tonight from Dr. Deborah Garosa. Deborah, do I have to introduce you? So, Dr. Deborah Garosa.
Well, maybe it's a good idea. I do not expect everybody to know who I am.
She is our chair, my boss at the ACNS, and the newly formed the ACNS Peripheral Nerve Committee. Our leader, very dedicated leader. So currently she is a neurosurgeon at Mediclinic Middle East, but previously I think she have a long time experience with peripheral nerve in Italy, and then she moved on to the UAE. So tonight she will talk to us about the ulnar entrapment. So please, Dr. Deborah.
So I start sharing my screen. Tell me if it's okay.
Okay, I see it perfectly.
Okay, great. Okay, so I'm absolutely delighted to see that our experiment of this course is actually going on, and I think quite well. So now today is my turn to talk about ulnar nerve entrapments. As everybody knows, we can actually have an entrapment of the ulnar nerve at the elbow or at the wrist. Chandan has already mentioned that cubital tunnel syndrome, which is also another way to talk about the ulnar neuropathy at the elbow or the ulnar nerve entrapment at the elbow, represents the most frequent compression neuropathy in the upper limb after carpal tunnel. And I'm not going to deal with epidemiologic data and just try to focus especially on the clinical presentation and the etiology. So ulnar nerve entrapment at the elbows might be idiopathic or might be secondary. When we talk about the idiopathic forms, we basically distinguish two causative mechanisms that related to compression and another condition, which is the hypermobility of the ulnar nerve. So in terms of compression, there are actually several sites where the ulnar nerve may result compressed at the level of the elbow. But they are not as statistically frequent at the same level. So you may have a very proximal compression at the level of the arcade of Straders, and that's a quite unusual site of entrapment. You see it in a very few patients. You may have a compression at the level of the medium intermuscular septum. But the most frequent situations are those related to compression of the nerve at the edge of the os bourse aponeurosis, because there is a thickening of the structure. And then probably in approximately 10% of cases, you may also find a compression between the two heads of the flexor carpi ulnaris. Usually these are fibrous bands, and this kind of compression is something that you mostly see in patients that present bulky muscles. So they are usually more male patients. The other condition that might be responsible of the onset of an ulnar neuropathy at the elbow is the hypermobility of snapping ulnar nerve. And before we talk about that, we better remember that there are some physiological changes that occur during the movement of elbow flexion. So whenever you flex your elbow, you are going to have a reduction in the height of the cubital tunnel that goes from 6 to 3 millimeters. There is also an increase from 7 to 18 millimeters in endoneural pressure. There is an elongation of the nerve that may go from 4 to 7 millimeters, and then there is also a displacement which occurs medially of approximately 7 millimeters. Now, What is important to note is that here you see what happens during elbow flexion and extension. What is important to note, as I said, is that there is a percentage that in the literature is reported between 15 and a little bit less than 40% that actually present a tendency of the nerve to present a medial displacement which is superior to 7 millimeters. This results in a subluxation of the ulnar nerve on the medial epicondyle during elbow flexion. And this might be related to the fact that we have the opposite situation that we mentioned before. Before we mentioned that compression may be related to excessive thickness of the Osborne aponeurosis, but you may also have the opposite situation. The Osborne aponeurosis is actually too loose, or it can be absolutely it can be not present at all, like for instance in this case where the patient presented a congenital absence of Osborne's aponeurosis. Now, here you can see what happens when, for instance, you also have the association of not only a displacement of the ulnar nerve, but also a displacement of the triceps. So you have a snapping triceps and a snapping ulnar nerve. Now, this situation is apparently asymptomatic in the majority of patients. However, there is some suggestion in the literature more recently, and I have to say that this is also my personal experience, that probably the presence of a snapping ulnar nerve may represent a condition that predisposes patients to develop ulnar nerve neuropathy. So other causes may also be related to secondary causative mechanism. So we have already heard something from Chandan, because there might be, for instance, conditions like bony changes of the elbow that may occur if the patient has, for instance, a rheumatological disorder, if a patient had a previous trauma that caused an elbow fracture that may have resulted in a malunion, if the patient has, for instance, the development of osteophytes of the ulnar emeral joint. And there are also other anomalies, such as, for instance, the persistence of the epitrochleal muscle. But sometimes the entrapment may also be related to the fact that there is a tumor. There might be a lipoma, for instance, or other forms of the tumor that grow inside the passageway of the ulnar nerve at the elbow, and might be responsible of giving a compression on the ulnar nerve. Another cause, and this is something that we have to be particularly careful, is that sometimes prolonged pronation on art surfaces, that is something that may happen, for instance, when we malposition the patient during a general anesthesia, may eventually also trigger the onset of these symptoms, especially in those patients that may have presented an hypermobility of the nerve. So the final result is that you have the nerve entrapped between the heart surface and the medial epicondyle. So how we should diagnose a patient with cubital tunnel syndrome? Well, Chandan has already mentioned before that it's very important also to consider that the suspicion should be born in our mind first as a clinical diagnosis, and then we have to ask for investigations that are going to confirm the clinical suspicion. So when you have a patient in front of you that you may suspect that they present an ulnar nerve entrapment at the elbow, you always have to consider that you have to listen to the patient, know what's their medical and social history, focus on the clinical presentation, and then of course it's very important to start to examine the patient neurologically, and then you request investigations that are supposed to confirm your clinical suspicion. So some factors that might be responsible of triggering this kind of neuropathy. There is a correlation between the high body mass index and the onset of ulnar neuropathy. And actually, for instance, this is something that I have seen in my series. Patients who have overweight seem to be more predisposed to present this kind of pathology. Also, what the patient does. So, for instance, nowadays, I have to say that I see probably higher percentage of patients with this kind of entrapment in the past. And this is related to the kind of lifestyle that we have nowadays. A lot of patients do office work. We all spend long hours typing or, texting on the smartphone. So office work is actually something that I have seen responsible of increasing the percentage of these patients. And especially the overuse of the smartphones or other electronic gadgets, I would say, as a role. If you pay attention to the picture here on the right of the screen, you can see what is the position that the hand is obliged to have when we hold a smartphone in our hands. As you can see, there is an ulnar deviation, and that, of course, means that there is a contraction of the flexor carpi ulnaris. So especially if there is already a condition of anatomy which is predisposing, this, of course, may eventually trigger the onset of the pathology. It's important also to consider what is the profession of the patient. From the literature and also from my personal experience, we have seen, for instance, that some musicians, like the ones playing the flute of the violin, that implies that they keep the elbow bended for long hours, might be predisposed to develop this kind of pathology. Sport, which imply a repetitive extension and flexion of the elbows, and in particular weightlifting. Clinical presentation has already somehow been mentioned by Chandan. So we know that there is the onset of pain and paresthesias which affect the distribution of the nerve. So in this case, we are talking about the little finger and the ring finger, half of it. Although I have to say that sometimes, occasionally, and this might be related to anatomical variation, there might be patients that present also the radiating of pain and paresthesias on the middle finger. Now, what is typical, and this is something that we found in all the entrapments, pain and paresthesias may typically worsen at nighttime, and this is especially if the patient presents the habit of sleeping with flexed elbows. Or, for instance, another situation is if they have the habit of leaning on elbows on hard surfaces. Now, the stage of pain and paresthesias may eventually progress if the compression is ongoing and it's not treated. The patient may eventually develop a progressive reduced hand grip, and in the most severe cases, we may end up also having a muscle waste and a typical claw deformity. Now, when we examine the patients, of course, we have to test the motor and the sensory function, but there are also some neurological semiotics that all peripheral nerve surgeon knows are part of our examination. So we test the Froment sign, which is asking the patient to hold a piece of paper in between the thumb and the index, and you have to try to steal it from the patient. And the patient has to hold it without flexing the thumb. The Wartenberg sign, which means that the patient has the ability to keep the little finger in abduction, even if you try to force it in abduction. And then the Tinel sign at the elbow, as Chandan already mentioned, and then the possibility to trigger a worsening or the onset of the pain and paresthesias in the ulnar nerve distribution when you do the elbow flexion test. And after a few seconds, the patient is starting to tell you that they have pain or they have paresthesias in the ulnar distribution. Now, once you have raised your clinical suspicion, of course, you need a confirmation of it. And so the diagnostic assessment traditionally was only with electrodiagnostic test. But nowadays, we know that in association with EMG and nerve conduction study, we also consider the introduction of imaging essential. even in entrapment syndromes. So EMG and nerve conduction studies are important, not also because they may give the confirmation of the entrapment, although we have to consider that occasionally they might be unremarkable when there is an hypermobility of the ulnar nerve. But they are also essential when you have an ulnar neuropathy, because it's the way that definitely gives you the differentiation between an entrapment at the level of the elbow or at the level of the wrist, which, as we are going to see later on, may be also clinically done, but it's quite tricky. So you really need the EMG nerve conduction study to confirm the site of the entrapment. We also have to consider that EMG and nerve conduction studies may be responsible of highlighting anomalies that might be consistent with entrapments also in other sites. Now, we know that we have a so-called double crush or multiple crush syndrome that implies that there might be an entrapment of the same nerve at multiple sites, or there might be an entrapment of several nerves. But we also have to consider, and this is very important because sometimes I have seen patients who have been given indication, redundant indication for surgery, that if you, for example, have an EMG and nerve conduction study that detects anomalies consistent with cubital tunnel syndrome and the carpal tunnel syndrome, if on your clinical examination you do not have an evidence of symptoms in the medial nerve distribution, that is not an indication for surgery that you have to give. So you only operate the cubital tunnel syndrome. We do not operate entrapments only because they have been detected on EMG and nerve conduction study. This is something that I consider very important. You need the EMG and nerve conduction study to confirm your clinical suspicion, but if the EMG and nerve conduction study gives you evidence of anomalies in a site which is not consistent with the clinical presentation of the patient, you do not operate only because of the electrodiagnostic anomalies. Dynamic ultrasound is absolutely essential. It's a paramount because it what helps us to distinguish if the patient has a compression or if the patient has hypermobility. So not only it can actually highlight the presence of the snapping ulnar nerve and tell us if there is also a snapping of the triceps, but it can also notice some morphological changes, like for instance a thickening of the nerve. This is something that we usually see on ultrasound in cases of prolonged ongoing compression on the nerves. And screening patients with electrodiagnostic test is important. With the ultrasound, it's also important because we are not supposed to forget that there might be conditions which are uncommon, but that might mimic the presence of an entrapment, but in reality, they might be related to other situations. So these, for instance, are two cases. One was a case of a patient with neurofibromatosis, where, as you can see, there were 3 tumors, which were 2 schwannomas proximally and distally, and then there was also a small neurofibroma that was right inside the cubital tunnel, or the case on the right that was actually a pseudotumor, inflammatory pseudotumor of the ulnar nerve. So 2 conditions which were not pure entrapments. If the patient has a past medical history of elbow trauma, or in those cases that might have been operated with failure, and I see quite a lot of them because I'm sorry to say that, but the majority of the patients I have done for revision surgery were not studied with an ultrasound. Only with the EMG nerve conduction study, so the hypermobility of the ulnar nerve was not detected. So if there is a history of past medical or past trauma, past elbow fracture, X-rays or CT scan may be indicated. And MRI are usually something that I advise in case of more complex cases that have to go for revision surgery. So how do we deal with entrapments of the ulnar nerve at the elbow? Well, of course, if the symptoms have started recently, if there is no evidence of sensory or motor deficit, we give an indication for conservative treatment. But if the compression has caused deficits, or if the symptoms have been persistent and there's been a failure of conservative management, we will go for surgery. Now, talking about surgery becomes a little bit more complicated, because as we know, for the ulnar nerve entrapment at the elbow, we have actually several surgical techniques, which might be basically distinguished into groups. We have the so-called transposition techniques and the decompressive techniques. The transposition techniques include anterior subcutaneous transposition, intramuscular transposition, and submuscular transposition, which is also known as Lermont's technique. The decompressive techniques include the simple in situ decompression that might be done as open surgery or endoscopic release, and then the medial epicondectomy. Now, medial epicondylectomy has to be abandoned because it has definitely been documented to be associated with an extremely high rate of recurrent symptoms and complications. I would say that also intramuscular transposition should be abandoned, because it also results in high incidence of complications due to intramuscular scarring and fibrosis. And when it comes to submuscular transposition, this is usually not the first choice, but it's indicated only in cases of revision surgeries after failure of anterior subcutaneous transpositions. Although it's my duty to mention that if you see in the literature, some authors favor it as the first choice for professional athletes that performs sports that would imply repetitive flexion and forceful extension of the elbow. But again, as I say, this should not be considered as a first choice. So currently, the most popular techniques are definitely the simple in situ decompression and the anterior subcutaneous transposition. The simple in situ decompression and anterior subcutaneous transposition may be decided based on different points that we're briefly going to list. So for most surgeons, simple in situ decompression is usually the first choice. And this it may be done as open surgery or endoscopic release. Personally, I do not have any experience with endoscopic release, and I'm not a fan of endoscopic release, both for carpal tunnel and also for ulnar nerve entrapments. So simple in situ decompression is a quite simple technique, because it just implies a resection of the Osborn's aponeurosis, and it provides a very fast post-op. However, we have to say that there are cases when it should be completely contraindicated. So this is, for instance, the case of patients that present elbow fractures or bony changes. There is an absolute contraindication to simple in situ decompression. And the other situation that contraindicates simple in situ decompression is the hypermobility of the ulnar nerve, because actually, once you have resected the Osborn aponeurosis, you may trigger a secondary hypermobility, or if this condition was already present, then it may even get worse. So, at least in my experience, and we may see if this is also the experience of the chairman today, I have to say that, for instance, all the cases I have done that were revision surgery were patients, as I said, operated by other surgeons without a diagnostic assessment, including a snapping ulnar nerve, and they did the simple in situ decompression, and the patient had only no resolution of symptoms, or maybe just a temporary resolution of the preoperative symptoms. So, for instance, this was a case of revision surgery where the patient was treated only with a subcutaneous, with a simple in situ decompression, and because the hypermobility was already present and it actually got worse, the patient even developed a neuroma. So there is now some orientation in the literature that because simple in situ decompression may actually induce the onset of an hypermobility, we may also consider that anterior subcutaneous transposition may be the first choice. And personally, to be honest, this is something that I nowadays prefer. So we are going briefly to review which are the main landmarks when you do this surgery. Considering that we need, of course, a good decompression of the ulnar nerve, we have to pay attention to the branches for the flexor carpi ulnaris, and we have to prevent the possibility of further entrapments, further compression sites. So these are, again, we have seen before cases of patients with a snapping ulnar nerve. And this is very clear. I want to show that because you can see how with the resection of the Osborne aponeurosis, the subluxation becomes even more evident. You can see here the nerve is completely snapping on the ulnar nerve. So when we perform this surgery, I recommend that the incision has to be approximately 14 centimeters because otherwise it does not really offer you the possibility to perform the subcutaneous transposition in a correct way. So, and when you do so, you have to be very careful to not resect cutaneous branches because they could be related of the onset of symptoms which may bother the patient in the ulnar area. I also play meticulous care in dissecting and mobilizing the branches for the flexor carpi ulnaris. And after resection of the intermuscular septum, this is something that is essential. I eventually transpose the nerve, and then I prepare a sling with subcutaneous tissue, and so that I can create a tunnel, a soft tunnel, which is the new passageway for the ulnar nerve. Okay, so now this is and then. Before doing that, I always try to see if there are no sites of entrapment or as Chandan said, we always have to be sure that passive extension and flexion doesn't evidence that there is any other compression. In those cases, when there is also a bulky triceps, a bulky snapping triceps, there might be also an indication to a local transposition of excision of the offending snapping medial portion of the triceps. So again, I want to emphasize, if you have to study these patients with ultrasounds, because you always have to be concerned about the presence of the hypermobility, and if there is an hypermobility, just consider to go for the anterior subcutaneous transposition. A few more words about ulnar neuropathy at the wrist, also known as the entrapment Guyon canal. This case is more differently from the ulnar entrapment at the elbow, very frequently may be related to the fact that there are vascular anomalies. I've seen quite a few cases where there was an aneurysm of the ulnar artery, or sometimes there might be the growth of a tumor, like for instance a ganglion or small lipomas or desmoids in the Guyon's canal. But there might be also situations related to, again, bone injuries or changes of the bone that might be related to rheumatological disorders. There is a form which is a bit peculiar, and this is one of the reasons why Guyon's canal syndrome is also known by some others as the cyclist palsy, which is related to prolonged wrist dorsiflexion and compression on the handle of the bicycle. Now, Guyon's canal syndrome is a little bit tricky from the point of view of the clinical presentation, because depending on the precise site of the compression, we may have 3 different clinical forms. So we may have motor and sensory deficit, which are related to the compression of the trunk of the ulnar nerve. But then, if the compression happens when the ulnar nerve has already split into its terminal branches, we may have only motor deficits or only sensory symptoms. As I mentioned before, there might be actually the possibility to clinically distinguish if the entrapment of the ulnar nerve occurs at the elbow or at the wrist. But this is actually quite difficult because it's based on the involvement of the dorsal sensory branch of the ulnar nerve. So this is why we definitely need the nerve conduction study to know with security where the entrapment sits. And then, of course, again, you may have a conservative treatment, or in those cases where there is a failure of conservative treatment, or if there is evidence of some of the causative mechanism I mentioned before, you may have decided to go for surgery. So thank you for your attention, and of course, I'm available for questions.
So please type in your question in the Q&A box, everyone. Thank you, Deborah. I think today we cover the most common compression neuropathy, and I think it's the most performed procedures in peripheral nerve surgery too. I think both procedures are essential for us, for young neurosurgeon it should be included in our neurosurgery curriculum, and neurosurgeons should do it with confidence. So thank you for your talk. For right now, I think we have time for
We
few
can
questions.
take the quiz.
Okay, so we move on to the quiz.
So the quiz, I'll launch the quiz. I hope you are seeing the questions on the screen. There are 8 questions, all single answer, multiple choice questions. Please attempt. There are 105 participants today, 97 are attendees. We request everyone to please take the quiz. Okay, we are done. I will end this poll now, and I will share the results with you. So, Dr. Ikaput, would you like to read out the answers and corrects?
Okay, the first one, which is the best diagnostic workup in ulnar neuropathy? The correct answer is both ultrasound, both EMG, nerve conduction study, and ultrasound. C. And the second question, which is the
number of people who have got it correct is
the number of
60.
people, 60%, 75% of the answer. So the second question, which is the most appropriate technique in case of ulnar neuropathy with hypermobility of the ulnar nerve? The correct answer is the anterior subcutaneous transposition. The people do it correctly is 70%. The third question, which form of clinical presentation can you find in ulnar entrapment at the wrist? The answer is both sensory and motor symptoms. 66% do it correctly. The fourth question, Martin-Gruber anastomosis is between the following nerve. Okay, the correct answer is the median and ulnar nerve. 93 of participants do it correctly. The fifth question, the cross-sectional area of the median nerve in the carpal tunnel syndrome the correct answer is more than 10 square millimeters. 74% of participants correct this. The sixth question, the first step in entrapment neuropathy. The correct answer is the breakdown of the blood-nerve barrier. Only 45% of participants correct this question. The number 7, C5 radiculopathy mimics. Okay, the correct answer is the suprascapular nerve entrapment. 55% do it correctly. The last question, which of the following is true for surgery of entrapment neuropathy? So the correct answer is that number 4, dynamic motion testing should always be performed intraoperatively to check for adequate nerve decompression. 64% of participants do it correctly. So I show the answer to you all.
Okay, so with that, we
Okay.
can wind up.
Okay. I think we done for this session. A very good session. I think it's very essential diagnosis and procedure we perform in everyday nerve surgery and also in neurosurgery. Thank you for all participants, all speakers, and all the moderator. Okay. Deborah, do you want to speak anything?
Yes, to be honest with you, I am a little bit disappointed that after we have done 2 webinars talking about basically diagnostic assessment, because we have talked about diagnostic assessment last time, and now this time we still have participants that have not understood that EMG and nerve conduction study alone are not the golden standard to study entrapments nowadays. This has been clearly mentioned in the previous webinar, where we showed the importance of ultrasounds, and this has been again highlighted today by the talks that we heard today. So the fact that you still have a 20% of participants that believe that if you just do an electrodiagnostic test, that's enough, when we have so specifically highlighted the importance of ultrasound, is, from my point of view, a little bit disappointing. So either these people were doing something else, or I don't know, we have not been particularly convincing as speakers.
I think this is what we try to convince all participants, because if you look at some recommendation from maybe some orthopedic practice, I have read some kind of orthopedic recommendation. It's kind of very official recommendation that carpal tunnel is only clinical diagnosis. You don't have to do nerve conduction study. You don't have to do imaging. But yes, it's sometimes it's not just clinical. It's something that can mimic carpal tunnel syndrome, ulnar nerve neuropathy. So I think this is what I and Deborah try to emphasize. With kind of developing world, we have a lot of technology that we can integrate in our practice. It's not just 20 years ago, 40 years ago that we don't have any tools. So I think if we have modern nerve conduction study, if we have modern ultrasound or imaging study, that's what we should implement in our practice.
Yeah, exactly. So, and again, because you mentioned that somebody says that clinical diagnosis is enough. Okay, so we try to very clearly highlight, this is a concept that was mentioned by Chandan, and is a concept that was then manifested again both by Ferry and me in our talks, that of course the clinical diagnosis is the first step. You need to have a clinical diagnosis in your mind, but then you cannot go for surgery unless this clinical diagnosis is confirmed by your investigations. So, you know, as you say, Ika, nowadays we have changed the way we do medicine, because we have a lot of technology that we did not have 20 or 25 years ago. So we have to use it, because at the end of the day, and this was also something that we try to show today, and this is the reason why we have Moaaz Elsebaey with us today. We have technology that can help us to be more precise, more accurate in the diagnosis, and this of course results in a reduction of the complications, and also in a better and more accurate treatment of patients for their benefit.
Yes, I think it also help us in kind of, if we face medical legal issues too.
Exactly.
Right. Thank you very much. So now we have come to the end of today's session. I would like to mention that all these webinars are archived on the ACNS YouTube channel. Just I will share one video where to find these webinars for you, and then we'll wind it up. I hope you can see this.
So let's say I post the answer you asked in the YouTube channel. The question and answer.
Okay, so thank you very much for watching, and hope to join you again.
Okay,
Dr.
thank
Para?
you, thank you,
Thank you,
everyone.
Thank you.
See you all.